Good afternoon, everyone, and welcome to today's discussion. Our topic for today's roundtable discussion is Rare Disease Policy, Scope for Inclusion and Treatment of New Rare Diseases on the occasion of the World Rare Disease Day 2022. I am Dr. Ratna, and it is my pleasure to invite and welcome all the panelists who have joined us today on a Saturday afternoon. It is indeed our honor that you have agreed to speak for this particular topic that we will be discussing today. My special thanks to Ritu from Singapore. I know it is quite late there, and Paul from Philippines. Again, I know it's quite late there. So thank you, both of you, for joining us today. We have several speakers who will be speaking on various topics, but before that, just to lay the ground, my organization, as you see, Dakshama Health and Education, which is the short form for Dakshayani and Amravati Health and Education, is a not-for-profit that was registered in 2012. And we work with patients and patient groups to raise their voices and bring them to the policy forum so that their experiences can be heard and incorporated into policies. We work in non-communicable diseases, rare diseases, and sometimes even communicable diseases that are lifelong, like HIV and Hep C. As you all know, the UN Rare Disease Resolution was admitted on December 16th, 2021, and it was sponsored by 3 countries. I think it was Qatar, Brazil, and Spain, and it was also agreed by 54 other countries. And this is a landmark because it brought to the focus that patients with rare diseases, over 300 million across the globe, have an equal right to equity in healthcare, and that healthcare and health system should take care of their needs as well. In the same year in 2021, Indian government also came up with the National Policy for Rare Diseases, and it had the ability to manage a large number of rare diseases in the context of India. It laid out a well-drafted plan on how some of those diseases would be not only identified, diagnosed, but also treated, and how their treatment pathways would be defined. However, we know that the spectrum of rare diseases is very large. They say over 7,000 rare diseases, and obviously the policy cannot in writing confirm all of those. So while we have a defined pathway for some of those rare diseases, there is always a scope to include a few more. So today's discussion will explore how those diseases that are not yet included into those lists, especially those that deal with dermatological rare conditions, can be included. And we can then probably discuss and agree on a path forward. It is therefore my pleasure and extreme honor to be able to invite to the floor our chair for today's roundtable discussion, Dr. Ramesh Bhatt. Please allow me to introduce him. He is the Vice Dean, Father Muller Medical College and Mangalore, and the Director ILDS and the past President of IADVL. He's also the international director, was the international director 2019 to 2023, and teaching experience for about 30 years. He is the Honorary General Secretary, Indian Association of Dermatologists, Venereologists, and Leprologists, and a WHO expert on neglected tropical diseases. He has won several awards and he has over 138 publications to his credit. He has contributed 6 chapters in textbooks. He has contributed to various research and clinical trials and conducted 10 research projects and 22 clinical trials, specially focused on psoriasis, acne, atopic dermatitis, and other dermatological conditions. Welcome, Dr. Bhatt, and the floor is over to you.
Good afternoon, everybody. Can you hear me?
Yes, we can.
Yeah. First of all, let me thank Dr. Ratna Devi and the organization Dakshama for giving me this opportunity. In fact, I came to know about Dr. Ratna Devi just a month ago, and because of my involvement in patient organization working groups, I am the vice chairman for ILDS coalition with the patient organization working group. So I sincerely thank for her for inviting me. I will just give an example how the rare diseases are not recognized by our system. In fact, I had a case of systemic mastocytosis about 4 years ago. And I have published a paper where we had given interferon. So interferon is considered as one of the drugs which can be used. It is not the drug of choice, but it is recommended by a few people, and I also used successfully. So a patient came all the way from Bhubaneswar for this management, and he was denied the insurance insurance coverage for the treatment. So in spite of being a central government employee, that is because the disease was not listed. So there is a need to list various not only dermatological diseases, but also other diseases by the government. So we have our government representative also here. So I request him to see to that all these diseases are included for in the health sector for insurance and various coverages. As far as dermatological rare diseases are concerned, we have mainly genetic diseases and rare diseases. Among the genetic diseases, we have conditions like ichthyosis, the blistering diseases like porphyria and epidermolysis bullosa, and then we have pigmentary diseases, albinism, and then various reticulate pigmentary disorders, and we have neurocutaneous diseases like neurofibromatosis, tuberous sclerosis, and as far as the acquired diseases are concerned, we have lots of autoimmune diseases which are not very common, but at the same time they are not very rare. And previously we didn't have an option for treatment of these conditions, but nowadays we have got newer drugs in our field. And in fact, ILDS is trying to ask WHO to recognize biologics as one of the essential drugs in the management, because many of the diseases now are being managed with the biologics. So today we will have eminent panelists along with us to discuss these various issues. So firstly, I request Dr. Muralidharan Rajgopal. So he will talk about dermatological rare diseases in India, burden and access to treatments. So Dr. Muralidharan Rajgopal, he is a senior consultant and head dermatology of Apollo Hospitals, Chennai. He is a postgraduate from PGMER Chandigarh, and he is my close friend also. So probably he is the one dermatologist in India who has used biologics in various dermatological conditions. And in fact, if we have got any problems with all these newer drugs, we just contact him regarding how to go about. And he is always helpful. And in fact, today morning also I had discussion with him. So I welcome Dr. Muralidharan Rajgopal and to speak about dermatological rare diseases in India, burden and access to treatment. I request all the speakers to stick to their time so that we will have some time for discussion if required. Over to you, Dr. Muralidhar.
Thank you very much, Dr. Ramesh. That was extremely generous of you to say those kind words. But knowing Dr. Ramesh for so many years, he has always been very generous and helpful in many ways, both academically and otherwise. I'm grateful for that, Dr. Ramesh. It was very, very kind of you to acknowledge that. I'm also happy that I'm here with a totally different group. The Rare Disease Foundation, as I honestly did not know that this foundation existed until they contacted me, I think 2-3 weeks ago. And I'm glad that this is happening. And I'm also extremely happy to see that we have representation from the Government of India and also representation from patient organizations. I'm glad to see Paul Mendoza here. I've heard of you, but I will be waiting to listen to your talk. I will share my presentation with you. Why is this? It is not accessing my desktop. So
Can we share it from our screens?
yeah, share it from yours. I've not changed it.
Sure.
We've done about 1,000 Zoom chats in the last year, but I don't know why this. Anyway, thank you. Could you just put it here? So I will be talking on dermatological rare diseases in India, burden and access to treatments. Now, at the outset, I would like to say that please make up your opinions about what I am going to say at the end of the hour when the discussion is over, because some of the points that I would like to bring forth are actually important, but may seem a little odd. But I'm the one person who has always called a spade, and that's the only way we make progress. Can we go to the first slide? Now, the scope that was given to me at this meeting is listed out here: the socioeconomic assessment, recommendations for initiatives, screening criteria, protocols of treatment, public awareness, and what would be a systematic approach that can help. So this is the scope that was listed out to me by Dr. Ratna and her colleagues in the previous meeting. And so I will stick to the scope, so I stick to time. Next, please. Dr. Ramesh has already spoken about some of the rare diseases that we see in dermatology. But when we talk about the socioeconomic assessment of the burden of disease, dermatologic diseases significantly affect the quality of life. This is something which is not very well recognized. And that is unfortunate. We need to create awareness on that. We do have metrics to measure the effect on the quality of life, like the HRQOL, which is health-related quality of life. We have these measures available, and a dermatologist can also note it down, so that if you are going to start a registry, which is what I'm going to come to, you will be able to actually measure the quality of life. So it's not just a question of rare diseases alone, but the burden of, if you look at the burden of just rare diseases, it is not going to be a very big burden because they are rare. But the burden would be, overall, if you look at the entire dermatologic diseases, then it becomes a problem. As Dr. Except in a few instances recently, we have not done this to arrive at a cost-benefit analysis of intervention for rare diseases or diseases that are difficult to treat through conventional means. The best example is a justification for biologics in dermatology. I started using biologics, and many times when I would lecture on biologics, I would be asked to justify why should we spend so much money on it. And a lot of cost benefit analysis have been done on biologics in dermatology. Unfortunately, no such assessment has been done in India. So overall, if you look at it, whether it is a rare disease or it is not a rare disease, the country does not know what it is losing when a citizen suffers a dermatologic disease. Now, I speak as a dermatologist. Now, as a dermatologist, I will be coming to that shortly. You'll understand why I'm taking a broader perspective. I will reiterate, we don't know what we are losing when somebody suffers a dermatologic disease. We really don't know that. Next, please. Now, this obviously will affect the policy planning, budgetary allocation for health, and certainly insurance coverage, as Dr. Ramesh so elegantly pointed out. Next, please. Now, the problem with dermatologic rare diseases, you can, somebody told me the other day that there are 8 rare diseases. I beg to disagree. There are hundreds of rare diseases. So dermatology is a very, very vast field. It's a much more complex field than any branch of medicine. There are more than 100 well-documented diseases which are very rare, depending upon the criteria used to define rare. And we don't have any criteria for that as to say what is rare and what is not rare. And, you know, in a country where there is no registry of all diseases, one cannot give figures and evidence to support this is rare or that is not rare. Now, for example, if you look at, I mean, I know a lot of people resort to doing Google searches for all these things. And if you look at it, the first 5 searches will mention 5 different groups which they consider rare. And one of them says pemphigus is a rare disease. I see 5 pemphigus patients every day. I will not call it a rare disease at all. Next, please. So we should know, the last line, please go back. So we should not rely upon subjective opinions. The whole purpose of this meeting is subverted if there is no clarity on how we define a rare disease and how we define the burden of a dermatological problem on the community. This is a very important point which I would like to highlight over here, because what is rare for you may not be rare for me, and what affects the economy of the country would not necessarily depend upon the rarity of a disease. Next, please. So some examples, if you look at my thoughts and my personal experience, congenital syndromes, including epidermolysis bullosa and its variants. And there is a very common condition called ichthyosis, but some varieties of a common entity of it, like ichthyosis, are extremely rare and could even be incompatible with life. I have worked on this and done biopsies of fetuses to detect if those types of lethal ichthyosis are there or not. And we have found that this is there. And psoriasis affects 3% of the population. By no means can you call it rare. It's a very common disease, but there is one variety of psoriasis which is also very rare, which is going to be discussed later on today. And there are some other variants of psoriasis which are rare. However, the point here is that the major burden is going to be in the common psoriasis patients. And the rare diseases, if you even are able to get 50 patients in the last 15 years, I would be very impressed. Primary immunodeficiency syndromes are important. There are variants of cutaneous lymphoma, an area where I have been, which is why I actually took up dermatology. I've been passionately interested in lymphomas. They are a malignancy of the blood which is present in the skin. They would look innocuous, just like a small whitish patch. But when it's very late, there's nothing much you can do, and the patient would die. And this would happen in an adult. So there are variants of this which are very rare, and I have a huge collection. Paraneoplastic syndromes, which are skin markers of malignancy, and metabolic syndromes, multiple metabolic syndromes. Porphyria is just one example of them. They are also rare, but this is also, once again, the rarity itself is not going to create a socioeconomic burden. But that does not mean that we should not have a uniform standard to approach all these diseases and pay special attention to the rarity of diseases. Next, please. So what is rare for most may not be rare for some. Now, I work in a tertiary referral center. I hardly see most of the common dermatologic diseases. I see 5 pemphigus patients. I see about 1 or 2 porphyrias every week. Per day, I see 5 pemphigus. So it all depends on, your type of practice and the type of referrals you get. Next, please. Now, the recommendations for initiatives to improve care quality in India. This is extremely important because care quality in India is, I feel, highly subjective. We need to start a national registry for skin diseases. Second, the common problem in India is what we call as academic high standing, where central institutes are regarded as the only indicators of good healthcare management. This is not a criticism of any institute, but this is what is happening in India. However, the private sector has repeatedly proved itself to be better than many centrally established academic institutes. And this has been reported many times because they have the facilities to deal with such rare diseases. We need to assure, therefore, a uniformity in following basic guidelines of care, whether it's a central institute or a private institute or a standalone clinic where a dermatologist is seeing 150 patients a day. I know excellent academic dermatologists who are working, but they do not come into the spotlight because of what we call as academic high standing, which is not right. We need to get above this mindset. No one is above the law, and the law here we are talking about is patient care. So patient care is what is most important. And over here, we need to involve insurers and educate them about dermatologic disease management. I have tried to do that twice, and both times it failed because they were just not convinced that diseases required this. Even diseases where we give certain types of therapy, they even question, why should you even admit the patient? So they are particularly ignorant about what is happening in dermatology. So continuing medical education is a must, whether it is for a practitioner in an academic institute or in a standalone institute or a private practice. A uniform continuing medical education is a must. This is the only thing which is going to improve care quality of dermatologic patients, especially rare diseases in India. Next, please. Screening criteria, treatment protocols, affordability. Is that a challenge to physicians for treatment? Now, expert consensus guidelines do exist for many diseases, and we should continue the effort to bring more diseases under the ambit. The protocols also exist. They should be made more adaptable to changing scenarios because it changes with the particular. Now, COVID was an example where we had to change our treatment protocols for many diseases and conditions. Affordability is a challenge, but this varies because the government of India does support. We have to acknowledge that in very broad terms that they're doing a wonderful job in supporting a significant amount of cost in government-run institutes where even expensive drugs are available easily to the patient. So even when you talk about expensive drugs like biologics, I know many state governments and central governments, they do take care of the cost. The question is the doctor going to prescribe the drug? The government makes the drug available, but is the doctor going to make use of the drug? That is where we go back to continuing medical education and assuring standard care of practice amongst all doctors. Outside this perimeter, even the best of doctors will find it difficult to get patients to buy medicines from out of their own pocket because they are not backed by insurers or the government. So this becomes a problem for the patients. I see this every day in my practice. And if there is a rare disease on top of it, where some of the treatment costs are way above what we normally expect, the patient cannot afford it. Next, please. There are challenges in terms of public awareness, early diagnosis, and treatment accessibility and availability amongst the general community. public awareness is a major challenge. Patients many times do not know where things are going wrong because they are not aware of what the disease is. And they are more often than not taking the help of media or the internet where they can access it to try. But more than 80% of India does not even have access to the internet when it comes to health-related issues. They have no reliable source to get information or how to find the right specialist for the particular disease. If Dr. Ramesh is an expert in systemic mastocytosis, we should have a method by which everybody who has systemic mastocytosis sees Dr. Ramesh. So these are the kinds of things we need to try to start implementing. Access to treatment is a problem in rural areas and tier 2 cities. And there are also cultural factors which impact this in India, like gender. I did a study, and it's under publication right now, where we evaluated patients with psoriasis, and we looked at their access to care, and we found that there was a glaring difference between how soon women or men were treated and or sought treatment for their problems. There exists no data, but my personal impression is that only 5% of our population, 5% of our population actually can access the best treatment practices. The rest are forgotten. I know this is a strong statement to make, but I'm sure that doctors over here will understand what I'm saying. Next, please. So this is the last slide. I've stuck to my time. What is the systematic approach that will aid in the development of a better framework for allocating resources and services to the patient in need? We have already covered all this in the previous few slides, and that can be submitted. And that is what this meeting is all about. The patient groups have to be led by erudite and non-biased persons. You should not have a bone to fry in this. Second, doctors' associations should cooperate with patient groups. Government agencies should have an open mind and cooperate with patient and doctors groups. There are private advocacy groups and which are led by people who don't have any disease, but who understand that there are people who suffer from disease. Pharmaceutical companies have corporate social responsibilities, and there are thought leaders who should be selected in an apolitical manner. Now, in many places, we find that thought leaders are not selected in the proper manner that they should be selected. I mean, democracy doesn't work over here. Only meritocracy works over here. Next, please. All should come together. So I think that in India, at this stage, all these previous 8 slides just showed you, so a very big thing to ask for. And I'll be extremely happy that to see how this foundation helps us as dermatologists to take this further and make sure that dermatologic diseases get the care and importance that they deserve, and especially some of the rare dermatologic diseases. Thank you very much for inviting me. Next, please.
Thank you, Dr. Murali, for you have presented nicely the various dermatological problems. So now, without wasting any time, I invite Dr. L. Swasticharan. So he is the Chief Medical Officer, Directorate General of Health Services, Ministry of Health and Family Welfare, New Delhi, India. I request Avinash to focus his CV slide. Avinash? Okay, so I invite Dr. L. Swasticharan to speak on inclusion of new rare diseases and access to treatment in India. Dear Dr. Swasticharan, so we are hopeful that you will be very helpful, especially for dermatologists, because we do not have access for many of our patients, the standard treatment that is required. In fact, when I was the national president of IUDVL, I met Niti Aayog chairman, Dr. Vinod Paul, and then I used to be in touch with the additional health secretary, Dr. Sanjeev Kumar and Dr. R.K. Vats. and even with the communications with Dr. Preeti Sudan. She was the secretary. So we hope that in coming years, you will help us in a great way, especially for our dermatological diseases. So I request you to take over and talk about the introduction of various new rare diseases.
Yeah, thank you, Dr. Ramesh Bhatt, and good afternoon, everybody. First of all, I would like to thank the organizers for giving me this opportunity to share some of the thoughts about the rare disease in India. The rare disease program has been there in the ministry for quite some time now, but after spending more than a decade in emergency medical relief and other non-communicable diseases, I ventured into the area of rare disease about June last year. The field of rare diseases, we all know that it's very complex and heterogeneous, and diseases are considered rare when they affect a very small percentage of the population. So I'm talking about disease in general, not just dermatological diseases. And hence, these diseases, which affect a very small population, they seem to have no takers. There are no treatments available. There are no doctors who are specially trained for them and easily available. So they are often called orphan diseases. And the drugs, again, this is a world of supply and demand. If you have a very rare disease, it is likely that you will have a treatment easily available for that. And so the drugs which are often used for treating these diseases, they are also called the orphan drugs. And unfortunately, because of this demand and supply mechanism, the prices of drugs are also exorbitantly high. So this is a major economic burden, not just on the family, but also in the country. And we are constrained by many things, and we are unable to provide as much as we want to do. Apart from this aspect of the prevalence and the treatment, there are also other challenges in the diagnosis. Early diagnosis, as my previous speaker has already said, some of the rare diseases, they will keep on shopping one doctor to another doctor, or from one hospital to another hospital, trying to find a proper diagnosis. And this challenge happens when there is a lack of awareness among the primary care physicians, and also lack of adequate screening as well as diagnostic facilities. So therefore, this delay is also going to increase the suffering of the patients and their family exponentially. The challenges in treatment, I would like to sum up that there is the unavailability of the treatment easily, and the prohibitive cost of the treatment. These are the two main challenges that we have in treatment. Sometimes the drugs would be on trials, and the trial drugs would not be available in many parts of the world, including our country. Therefore, I must say that the government was aware of all these challenges. So a policy to consider the available scarce resources and the need of the utmost judicious utilization for maximizing the overall health outcome was necessary. Therefore, in 2021, the national policy for the rare diseases was notified by the ministry in March 2021, and this policy was aimed at leveraging the incidence and prevalence of rare diseases based on the integrated and comprehensive preventive strategy. Under this strategy, in order to facilitate the proper diagnosis and screening, etc., we have identified 8 centers of excellences all across the country. I'm not saying that they are enough, but to start with, we have got 8 centers of excellences spread, in different parts of the country, and there is a provision of increasing the number of these centers of excellence based on some criteria on which we are working. These centers are mandated to conduct education and training at all levels, and screening and diagnosis, prevention, research, and treatment for rare diseases. Under the policy, as of now, we have got 3 groups of the rare diseases. The group 1 is a collection of diseases or disorders which are amenable to one-time curative treatment. And group 2, we have got diseases requiring lifelong treatment, but relatively at a lower cost of treatment, and benefits are documented in literature, and annual or more frequent surveillance is required. These are the other second group. The third group are those diseases for which definitive treatment is available, but challenges are to make optimal patient selection for benefit, and there is a very high cost or lifelong therapy associated with this. So these are the three groups that we have as of now. Now, the question is, if there is some disease which some of our clinicians in the country, and also including the dermatologists who are present here today, consider that a particular patient could be suffering from a rare disease, then what is the procedure? How do we do it? In the ministry, we have a committee under the Directorate of Health Services, which is known as Central Technical Committee for Rare Diseases, and this committee meets to discuss many issues almost once or twice a week as per the need, twice a month as per the need. And in the policy, there is also the provision of including a particular disease in the list of in the group 1 or group 2 or the group 3 accordingly. So the particular patient case-to-case basis discussion would be happen, and in that committee, the experts who are from the centers of excellence, as also eminent people in the field of rare diseases are there, and they will discuss on the criteria which I have already enumerated in the beginning, in terms of the prevalence, in terms of the treatment availability, in terms of the kind of cost of treatment, or whether it is going to be one-time management or a lifelong treatment. Accordingly, the experts opine if that particular disease is to be covered under the rare disease policy. Then once the decision is taken, and then we discuss further on, discussing with the treating physician. Say, for example, a case of dermatological case has been referred to the CTCRD. We, based on this criteria, we may agree that this may be included in the rare diseases policy. And the next step would be, we would be reaching out to the treating physician regarding certain criteria, and then we will be deciding whether it will be group 1, group 2, or group 3. So that's the provision that we already have. In the past 6 months or so, we had around 3 cases of diseases which were discussed in the CTCRD, and we had decided to include them under the rare disease policy, and then decide on the modalities of funding as per the policy directives. One of them was Laron's syndrome, and the second one was in Wilson's disease categorization, and the third one was hyperuremic syndrome. So this kind of incidence has already happened, and that provision is already there. I would also like to inform the August gathering here that this categorization is not just necessarily an academic purpose. As I said, the rare disease, the challenge is in terms of the funding, and that's why the funding mechanism which is available in the ministry as of now is one under the Rashtriya Arogya Nidhi, which is the fund which is given to the premier institutes of the country, to the state government hospitals, where the diseases under group 1 are provided. If some of you know, the RAN facility is provided generally to the people who are below the poverty line, the BPL families. But for the purpose of rare diseases, the clause that the patient should be, falling into the category of BPL has been lifted, and so anybody who is BPL or non-BPL can be supported if they are in group 1. So that's the provision that we have. And for the group 2, the state governments are requested to provide the treatment for those diseases under group 2. We all know that health is a state subject, and so the state has a responsibility for taking care of the citizens. But nevertheless, if a disease, if a case belongs to group 2, then that particular state government from where that particular patient has come would be requested to take care to support the diseases under to support the treatment care. The problem, major challenge arises because of group 3. These are lifelong, definitive treatment is available, but the challenges are to make optimal patient selection for benefit, very high cost, and a lifelong therapy. So 3A and 3B, these are, you are all aware of diseases like Duchenne's muscular dystrophy, spinal muscular atrophy, and lysosomal storage disorders, etc. So for this, under the policy, we are to have a digital platform, which the ministry has already done it. And here we encourage voluntary crowdfunding into this portal, and hope that when the donations come to this portal, through the portal, donations can go directly to patients or to the centers of excellence. And all the centers of excellence have already examined and listed the priority of the patients who need the treatment in terms of the urgency, in terms of the severity, and they put up in the portal according to the COE. So that kind of arrangement is there, and I would like to urge once again here that the rare disease policy is very much alive, and not just dermatological disorders, any other disorders who fall into the category of who fall into the possible category of classification under the rare disease policy. The mechanism under the CTCRD, the Central Technical Committee for the Rare Diseases, is already available, and we are doing it. And it is not just an academic exercise, and it is an exercise through which we are trying to provide support from the ministry in terms of diagnosis, in terms of screening, in terms of financial support through the centers of excellence under the 3 provisions that I have already enumerated. So this is what I wanted to share, and we all should raise the awareness about the rare diseases, the challenges. Personally, when I saw it for the first time, I thought it was a very big challenge. But when you go closer to it, I think it is not that big challenge that we had feared, and there are ways and means of doing it if our intentions and our efforts are sincere. I think we should be able to give hope to those people who are suffering from rare diseases and provide them some hope in the future. Thank you so much for giving me this opportunity.
Thank you, Dr. Swasticharan, for giving us the insight into the rare diseases and the various categories. And you have also told about how we can approach the government, and we hope that you will be helpful for various patient organization groups as well as for health associations in approaching the government in relation to these rare diseases, and you will help us in improving the quality of life among rare diseases. Especially we have in many dermatological conditions where it may not kill the patient, but they will have to live with the disease with the disturbed quality of life. So in these conditions, we solicit your cooperation, and I think through our association, we will approach you and the government for further needful. So thank you very much, Dr. Swasticharan. So now we will have the third speaker, Dr. Madhulika Kabra, who is a professor of Division of Genetics in Department of Pediatrics, All India Institute of Medical Sciences, New Delhi. So Madam will speak about the rare diseases policy and the categories 1, 2, and 3 and scope for inclusion of new rare diseases. I think this will be extension of what Dr. Swasticharan has told. Over to you, Madam. Please take over.
Hello, good evening, everyone. I would like to thank Dr. Ratna Devi and her team for inviting me here to discuss some of the aspects of rare disease policy and inclusion of new diseases. Actually, it will be a lot of repetition what Dr. Swasticharan has also spoken about, but I was asked to speak about that only, and maybe I'll have some slides and maybe some additional information which I'll try to add to the try to add to the information which Dr. Swasti Charan has already given. So can I share my screen now? Is the screen visible?
Not
Hello?
yet.
Okay.
Not yet, ma'am. So if you could share. Yeah, now it is started.
Is it visible now? Okay.
Yeah, it's
right.
visible.
Okay. So Dr. Swasti Charan has already given you an overview of the rare disease policy and about the new disease inclusion. I have included this slide for the clinicians, basically, that we should never forget when we are seeing a patient that always we think of common diseases first. But then whenever we are seeing even in a scenario of a common disease, it may ultimately turn out to be a rare disease. So rare diseases are compared to zebra as compared to horses, which we usually see routinely, and try to rule out horses first and then go to zebra. But then I think if we have to leave our we have to have information about this, and our mind should know about rare diseases so that we do not miss them. So just want to disclose that I'm a member of the Central Technical Committee for Rare Diseases for technical inputs. So we all know that impact of rare disease is massive globally, and there are about 7,000 rare diseases known. And as of now, only about 5% of these have treatments. But then I'm really hopeful because in the last 5 years, many of the rare diseases have now being treated, and we have in pipeline many treatments which are likely to come very soon. And about 80% of these rare diseases are genetic in origin. But then we need to keep in mind that many others, like immunological disorders, as was mentioned in the previous talks, and also many of the malignancies and many more are actually rare diseases, and they are not genetic in origin. So if we see in India, when the rare disease policy was being prepared, so there were many aspects which were to be taken into account when we talk of India, which includes epidemiology, because everybody wants to know what is the prevalence of a certain rare disease in our country, and we do not have such data available. The data which is available is usually hospital-based, and the registry which has been initiated by the ICMR will also be hospital-based. And then about the education and training in relation to rare diseases, availability of diagnostics, treatment facilities, public awareness, integration of services with the existing system, prevention programs, status of research, and all this. So based on all these, when the policy was drafted, all these aspects were taken care of. The treatment status, everybody was really worried about, and the treatment can be specific or supportive, and then the specific treatments for most is very expensive, and whatever treatment was available and still available is through many of the CSR or humanitarian initiatives through the companies. And here, being a pediatrician and looking after some of the specific rare diseases like lysosomal storage disorders, neuromuscular disorders, and so on and so forth, these patients are being treated through that. But I must say that many of the patients are also being treated by the reimbursement for which the parents are eligible. And similarly, there was a need to have guidelines for these treatment, because once you plan to treat these patients with these expensive drugs, then in that situation, we really need to see which patients are going to be benefited. So all this was kept in mind when the policy was being structured. So as you all know, it was first declared in May 2017, but later retracted. And finally, in March, it was declared again, and it has a more holistic approach, as Dr. Swasti Charan just mentioned. So this is just to give you the directions which the policy has, and you can see that it has an integrated and comprehensive approach, which includes awareness, counseling, prevention, access to affordable therapy, and the public health hospitals and state, being a state subject, it is being tried that there is a cohesion between the central and the state government, and central government is trying to sort of encourage the state governments to take up the area of rare diseases and support these patients. So these are the groups which Dr. Swasti was referring to. So group 1 is a one-time treatment, and this is under Rashtriya Arogya Nidhi. And the ceiling for this was earlier 15 lakhs, and this has been increased to 20 lakhs now. And as Sir mentioned, it is applicable more universally now, not only to the below poverty line group. And here primarily we are talking of transplants, where one-time treatment is available. The second group where the treatment is the cost is not that high, but though it's a lifelong treatment and the treatment benefits are well documented, this has been sort of responsibility has been given to the state government, and many of the metabolic disorders and many of the immune deficiency disorders are included in this particular group. The third group, which is the most difficult one to manage, is the group 3, where long-term treatment is to be given. And even within that, there are some groups of diseases for which we do have treatment, which is extremely expensive, but the long-term outcomes are not there. And here, primarily lysosomal storage disorders, cystic fibrosis, many of the neuromuscular disorders have been included. So for the third group, as Dr. Swasticharan said, voluntary crowdfunding has been planned for funding these patients. So as he said, it's a dynamic process. There's a periodic review and other disorders. So if you see the list under these 3 groups, there is a mention of others, which can be definitely taken up for consideration for funding. So this is just a slide which I made to communicate that how the consideration for including new disorders, as was mentioned, is being done. So the list of disorders is dynamic. You know, there are so many rare disorders, everything cannot be listed. So the request for funding for any other disorder can be submitted to the Central Technical Committee from the treating clinician, either through the Center of Excellence or directly. And what is expected is information about the disease, the therapy and the likely response to therapy, and cost of therapy. And again, as he already said, based on the cost and the duration of therapy, the disease is classified into either of the group, and also it is considered whether it is actually rare, and then response to therapy is going to be good or no. And after review, the disease is classified and decision is taken accordingly. So this is the way the clinicians can refer patients, which includes dermatological disorder, any kind of disorder for which the CTC, the Central Technical Committee, considers the patient for treatment. This is the portal which Dr. Swasticharan was referring to, and you can log in to see what all information is available, information regarding all centers of excellence, how to submit an application, how many patients are already there on the portal, what donations have already been received. So these centers of excellence as of now are 8, and as is being discussed, 8 definitely are not enough. But I think the reason of the ministry for including these 8 initially was to just set the ball rolling and see how these centers perform, and then later on other centers will definitely be included, so that we want to cover a larger proportion of the population. The responsibilities of the centers of excellence include not only treatment, but education, training, prevention aspects, which include screening, diagnostics, and research also. And treatment, obviously, is a very major mandate of the centers of excellence to provide. Research and development is also included in the rare disease policy, and various funding agencies like ICMR, DBT, DST, CSR are requested to promote R&D in the area of rare diseases, and they are really funding in the area of rare diseases through various projects. So this is the kind of way forward which we have to follow, that there has to be a networking between the regional centers, tertiary care centers, state medical colleges, and even the periphery, and interaction with the basic science institutions to promote research and have drug development in the country itself. So to conclude, I think we are in the beginning of a new era of rare diseases. There's a slow but steady progress, significant progress in diagnostics, and rare disease policy as a ray of hope for the patients and clinicians like us. It's a long way to go, but I'm sure with a combined effort, we can do it. Thank you very much.
Thank you, Madam, for giving us the insight regarding how to include new rare diseases, and you have shown us the category of rare diseases also. So now I request Mr. Paul Albert Mendonça. He is from Philippines. So he's the Vice President of Psoriasis Philippines and President of Psoriasis Asia Pacific. So we have heard a lot about Mr. Paul Albert Mendonça, especially his efforts in getting free treatment for psoriasis patients in Philippines. So he will tell us about the psoriasis groups in Asia Pacific, legislative and health systems changes to meet the needs of patients in the region. So over to you, Dr. Paul Mendonça.
All right. Good afternoon. Thank you for inviting me to share about the psoriasis advocacy that we are doing here in the Asia Pacific. Let me share my slides. So I'm here to talk about the legislative and healthy system changes to meet the needs of people living with psoriatic disease in the region. And again, I'm Paul Mendoza, President of Psoriasis Philippines and SOR Asia Pacific. And before I continue, I just want to introduce our organization. So we are composed of 16 member countries here in the Asia Pacific region, and we focus on capacity building and empowering our members to engage with their government in terms of policy making and health policies for psoriatic disease. As a patient organization, what is very important is for us to answer what are the needs of people with psoriatic disease or the patients that you are representing. And for psoriasis, it was a very challenging when we started this advocacy work. First, there are a lot of misconceptions about psoriatic disease. And before, if you search for psoriasis in the World Health Organization, it's just a one-liner telling that psoriasis is a cosmetic condition. But latest study shows that it is not just a skin condition, but there is something going on inside our body. And in 2014, in the World Health Assembly, the psoriasis resolution was approved, and they were encouraging their country members to focus on addressing the access of treatment for psoriatic disease. And on 2016, a global report on psoriasis was published, and this changed the ballgame of doing the advocacy work for psoriatic disease. Before this resolution, we were not really able to engage well with our government because it is not a focus of concern. But with this resolution, we have a bargaining chip where we can go to our local governments and demand that you supported this resolution. Then it's been years and there's still no policy in place for addressing the healthcare system or for the treatment for psoriatic disease. And this gave us a leverage to successfully engage with our government. There are some efforts in Hong Kong, in Vietnam, in Japan, and in Korea on how they can include psoriasis in the health system. Although most of us has still no policies in place for psoriatic disease, and a lot of patients still has no access to treatment, especially for biologics, due to high costs of these new treatments. And with this global resolution, psoriasis was redefined as psoriasis involved the skin, nails, and joints. It is a chronic, painful, disfiguring, and disabling, non-communicable disease for which there is no cure. And as we go on engaging with our local governments, these are some of the challenges that we face. First is there is no patient registry, so we cannot really give the exact data how many patients are suffering of psoriatic disease. Some of the countries, Asian countries, has no clinical practice guidelines in place. There is no scientific data that is available. Most of the studies, especially for these new treatments, are from the Western studies, and there is no really Asian studies about some of these biologics or even local studies about these biologics in every country. There are limited studies also in improving the situation for psoriatic disease. And most of the countries has no existing policy. And with these non-existent policies, there is no access to medicine and treatment as well. And the big question mark for us organizations, for us patient organizations, is how do we participate in engaging or in pushing for these health policies and the changes that we want so that the needs of the patients could be provided. I'm here to share our journey, how we are doing it here in the Philippines. We are sitting as part of the technical working group with our Department of Health and with Philippine Dermatological Society and Philippine Rheumatology Association in crafting a psoriasis health policy. We are also consistently engaging with our Philippine Health Commission so that a health package could be done for psoriasis, because right now there is no health packages available for psoriasis. And with some of our efforts, we have listed 14 medicines for psoriasis in the Philippine National Formulary. And it's very important that these medications are listed in the formulary, because our government will not be able to pay for these treatments if this is not included in this list. And right now, we are also focusing on the HTA submission, where we are pushing that biologics should be included here in the listing and hopefully be approved in the HTA committee, so that these medications, these new medications, could also have new health packages in our PhilHealth Commission. And since we were also pushing for a National Psoriasis Care Act, last year we started doing some draft on the bill, and on July, one of the congressmen heed our call, and she submitted the House Resolution number 9821, also known as the National Psoriasis Care Act, and it was approved on its first reading last November 16, 2021. And we are very excited of this progress, and it is very challenging because of the pandemic. We all know that most of the diseases are really left behind because most of the focus are in the COVID-19 pandemic. And we hope that this is the first step that we are making, and we are expecting more years before this becomes a reality, but we are still pushing and still negotiating with different legislators to champion and support this National Psoriasis Care Act, both in the Congress and in the Senate. For patient organizations, these are some of the recommendations or some of the things that we did. First, it's important to engage with your members, with the patient community, because as patient organizations, we are the one who can provide the burden of this disease and how these treatments can work and improve the quality of life when we have access to these treatments. Second is involve our doctors. We are blessed that we have a strong relationship and partnership with the Philippine Dermatological Society and the Philippine Rheumatology Association. And we are also active in the global and the regional organizations. It's really important also to connect with them, because some of the latest studies, especially done in the Western Hemisphere, through these organizations, through these global and regional forums, we are able to be educated and be informed of the updated medications, updated trends on treating our condition. Next is to really build a good network of support. Having a good alliances with different patient organizations, health advocates, and civil societies are very important You could also find other champions, health champions, who are pushing for health policies in your area or in your country. Research is also very important. And lastly is to participate whenever there is a chance for us to participate with our government. We are always there and always make time to be there. And we always say to them that we are just not here asking for help, but we are actually here to partner with you to find solutions. And we as patient organizations and civil society, we are also here to fill in the gaps so that we can help craft the best policies and the best healthcare system available for our community. And just want to share this quote from our founder, Mr. Joseph de Guzman. As patients, we are real experts of our disease, for we believe our illnesses day in and day out. Just like anyone else, each of us has his own hopes and dreams. Each of us has his own story to tell. We are in the unique time that these stories matters, and we need to be heard. And we are really fortunate that in this time, patients' voices are very strong, and our government really engages with us so that they can hear what our needs, to hear our inputs, and to hear our take on crafting these health policies. So thank you, and I hope that I've given you some ideas how patient organizations can play a big role in pushing for the changes in health policy in every country. Thank you.
Thank you, Paul. You have explained to us the role of psoriasis groups, especially in your country and also in Asia Pacific region, and how they can help in framing the health policies related to diseases. So you have given the example of psoriasis. So we should have psoriasis, not just psoriasis, even other diseases group which help in framing the health policies and helping the patients altogether. So now I request Dr. Ritu Jain, who is a board director of Global Skin, International Alliance of Dermatology Patient Organizations. In fact, we call it as IADPO. And she is founder and president of Dystrophic Epidermolysis Bullosa Research Association. So she will talk about the patient perspective and journey, need for dermatological patient groups in India. So in fact, I am the vice chairman for our ILDS coalition with IADPO for the various dermatological diseases. And I'm trying to find out the various patient groups in India. In fact, I could get a few for vitiligo and then for leprosy and not for many other diseases. So now I request Dr. Ritu Jain to highlight how the patient perspective and journey can help in having more newer groups and which will help ultimately in the patient care. Over to you, Dr. Ritu.
Thank you so much, Dr. Ramesh Bhatt, and thank you so much, Ratna, and everyone here. It's indeed an honor for me to be here and sharing the platform with so many esteemed speakers. I'm actually quite blown away. I thought I knew a lot about India, but what I hear today makes me so happy and so optimistic about the future of rare disorders, and particularly about the future of dermatological conditions in India, given the commitment that I've just heard about for the past nearly 1 hour. So I'm very happy to share with you my perspective as a board member of IADPO, or what we know more popularly as Global Skin, as well as my perspective from having set up Deborah Singapore just in 2015, not so long ago, and now chairing. I have the tremendous honor of chairing, presiding over both Deborah Singapore as well as Deborah International, the patient organization that I can proudly say is perhaps the most organized and the most effective patient organization in the world. So I'm happy to start with giving you a little bit of an idea about patient organizations and alliances. In my opinion, patient organizations work as a bridge between various stakeholders that the patients need to engage with. They serve as a conduit or a bridge between governments, policymakers, healthcare professionals, researchers, pharmaceutical companies, think tanks, and patients. And on the other hand, patients bring in their lived experiences and challenges, needs, priorities that only they know best about to the various stakeholders who need this information. So to me, patient organizations and patient alliances are absolutely critical in the healthcare system if we are to bring about any positive change in a caring, responsible healthcare system. Patient organizations play an absolutely incredible role and undeniably valuable role. So please allow me to share with you 3 case studies of patient organizations that are committed to dermatological conditions. Of course, I have many, many more, but I'm going to focus on the ones that I'm most close to and heavily engaged in. So the first of them is Global Skin, or IADPO. So what do these organizations do? Who runs them, and with what effect? Those are some of the issues that perhaps some of you are curious about. Excuse me. So IADPO is actually a global alliance of dermatology patient conditions. They are both rare and non-rare. And of course, they include eczema, psoriasis, and other non-rare conditions, as well as what are traditionally termed as rare, such as epidermolysis bullosa, pemphigus and pemphigoid, or ichthyosis, and vascular anomalies, etc. And I'm actually quite amazed every time with Global Skin at the breadth of the vision and impact that it has. The very organization that a handful of committed staff members and volunteers can bring about. So Global Skin has 187 condition organizations, or what we call members. They are not individuals, but organizations. It has these members span across 62 countries and cover 54 disease areas. So can you imagine the breadth of the collective wisdom, experience, and insight that these members, which are organizations, bring to Global Skin to fulfill its mandate and vision of ensuring that patients lead a healthy and fulfilling life, or should I say healthier and more fulfilling life, because that's still a dream that we aspire for. And don't forget that nearly 60% of the global population lives in Asia. Imagine how many in India. As we heard some of you speak about, that the very definition of what's a rare disorder can be challenged by people in perhaps India itself. Forget about Asia. So let me move on to telling you a little bit about DEBRA International. This is the organization that I currently chair. DEBRA International was founded more than 50 years ago. And it is based out of Austria, with some of the more successful DEBRAs being DEBRA UK, DEBRA Ireland, DEBRA of America. These are the more established DEBRAs globally, and they employ quite a fair number of people, and they invest millions of euros in research actually every year. In fact, I'm quite proud to say that of all the research being done on epidermolysis bullosa globally, DEBRA International probably has contributed to some extent, if not a lot, to this research. So what's DEBRA International? It's comprising of 49 DEBRA groups, both associate members as well as full voting members across the world. So there are DEBRA chapters in many of these countries, sadly fewer in Asia, but I'm trying to change that. And other than patient groups, of course, there are clinical contacts. So we have something called ClinNet. It's called EB ClinNet, or Clinical Network. So this map actually identifies where the clinical contacts are all across the world in case patient needs to see a doctor. as well as laboratories offering EB diagnostics. And if you go onto the DEBRA International page, you will see that it is a purely patient-led organization, with most DEBRAs, actually only rare DEBRAs, having leadership who are physicians or researchers. Most DEBRAs globally, if not all, are led by patients and family members. And of course, we do an incredible amount of work, such as creating clinical practices guidelines for both experts, such as clinicians, as well as non-experts, such as patients. We invest in research, we provide, or maybe I can tell you a little more through my slides. We offer grants that enable professionals to get training at centers, at opportunities we also create. We also give members grants for a specific member organization need. It could be fundraising, it could be having events such as we just funded in Pakistan and Cuba. And also we have an EB Without Borders team, which also I am a member of as part of DEBRA International. So EB Without Borders is a work stream of DEBRA International and is made up of purely volunteers. It responds to families and patients who may reach out to DEBRA International. And in fact, I'm quite proud to say that through EB Without Borders, we have supported, in fact, I have supported patient groups and individual patients in India, in Philippines, in Pakistan, in Indonesia, Malaysia, Vietnam, Sri Lanka. I mean, the list is really endless as to how many people we have helped. And uniquely, actually, I might just add here, also helped orphans who are often discarded by their families get adopted in a better environment. So we've helped orphans get adopted from orphanages, one in Hyderabad, one in Cambodia. So what else do? We offer clinical practice guidelines. We contribute hugely to EB research. We are a leading funder of EB research, and I'm really looking forward to hearing the news in 2 days about the first first intervention, a biologic that is going to be announced by Amrit Pharma. We are just waiting for FDA approval, which we hope will be with us in another 3 days or 4 days at the most. We organize annual conferences for researchers, for patients, and other stakeholders. The list is endless on the scope of activities that we, the patient organization, enable. So let me move on to DEBRA Singapore. This is the organization that's closest to my heart because I helped set it up in 2015 and have built it up to the level it is today. You might be shocked to hear that Singapore, despite being such a wealthy country and an advanced and developed country, actually does not recognize epidermolysis bullosa and offers absolutely no support to patients. In fact, unlike patients in India, who do have access to dressings and devices as outpatient in the outpatient care, as I've seen in AIIMS and PGI, etc., patients in Singapore have absolutely no support for this and have to bear this out of pocket. And many of you will be familiar that the dressings, the adhesive dressings for epidermolysis bullosa, are exorbitant. And today, DEBRA Singapore is in a position to fulfill the 100% medical care needs of all patients with epidermolysis bullosa in Singapore. I must say at this point that we have a very small population, so the number of beneficiaries we actually support is about 15. And of course, if this model was to be replicated in India, it would be very difficult to scale up to the population there. Regardless, it's a good case study to show that how, I should actually tell you all that I'm also a mother and wife of family members with epidermolysis bullosa. So how have parents like me set up an organization like DEBRA in their countries and brought it to a level where they have done enough fundraising, enough awareness creation? We actually have a documentary called The Butterfly Children on Netflix. And you can even watch this documentary on YouTube to talk about which sort of demonstrates the work that we've been able to do in Singapore to support patients with epidermolysis bullosa. We have all stakeholders as part of that documentary. So do watch to understand more about what DEBRA does in Singapore. We offer medical support. facilitate awareness, etc. And you might be interested in knowing that I actually became the liaison point for two pharmaceutical companies, Amicus and Amryt, to start clinical trials in Singapore. And many of you may be aware that clinical trials predominantly happen in the Western Hemisphere or in perhaps Australia, but clinical trials in the Asia Pacific region is extremely rare and devoted to just one country or two at the most in Asia Pacific. But we were able to bring two clinical trials to Singapore. Amicus had to abort later, but we had a successful clinical trial for Amryt here. What else do we do? Even though we are such a small DEBRA, we have no staff. I work with just a few very passionate volunteers here, and we lobby for policy change for affordable medical care. In fact, this year, I'm hoping that we will actually have we will have two patient members as part of the HTA process of Singapore, which is a game changer in Singapore for patient voices being involved in important policy decisions. We also support regional countries in the region. Countries in the region. Other than Cambodia and Indonesia, I've had actually at least four meetings with experts, 4 to 6 meetings with experts all over India. We've had a very good meeting with researchers and clinicians and patients in Philippines, in Pakistan. We've taken a training group to train doctors and clinicians in Bandung in Indonesia. So we've done so much that actually the list is endless, and I am aware of the time. I'm probably busting my time limit. So I'm going to conclude very quickly with showing you a snapshot of some of the events that we did. On the top right, you will see a multidisciplinary team from the UK and Singapore who visited the Center for Human Genetics, and you'll see the room is full of patients with EB. On the left is a fundraising event that we organized in Singapore, which raised us a lot of money. Bottom left is a meeting with some of the doctors at All India Institute, and you will see here in the third person on the right is actually the Chilean ambassador to India, because we had in the center these 3 doctors from Chile who visited AIIMS to talk about the need to have a DEBRA and a dermatological alliance in India. On the right corner, bottom, you will see the butterfly run that we organized in Singapore to create awareness. So why should we create alliances? So many benefits: sharing condition-specific information, promoting dermatology as a national health priority, as Paul has just shared with us, creating and enabling communities and raising national awareness of dermatological conditions. But there's one thing that it's very important to emphasize here, that patient alliances are a multi-stakeholder collaboration. They are not hierarchical. There is no someone at the top who controls these organizations. These are stakeholders who come together for mutual benefit, for mutual needs, mutual goals on an equal footing. And I think if we can keep our eyes on that objective, we will be in a stronger position one day. So let's get together and change the way the world sees dermatology and move from a we and them to us. Thank you so much.
Thank you, Dr. Ritu Jain. In fact, we salute you for the work that you have done in the field of epidermolysis bullosa. In fact, 2 of my friends from India, Rahul Mahajan and Dr. Ravi Hiremagalur, both of them, in fact, today we have a session in the night from 6 o'clock onwards. So epidermolysis bullosa is one among the subject of discussion from our association. And at the same time, we will be coming to Singapore next year for World Congress of Dermatology. So
I'm aware. I am aware, and I look forward to receiving you all. Please give my regards to both of them. And next year, I hope to be at the WCD and maybe also organize the annual meeting of DEBRA International back to back. So we will be in touch with you.
Yeah, in fact, your name is there in our possible speakers for World Congress of Dermatology. In fact, I was in the scientific committee also. So Your name I saw in the epidermolysis bullosa list. It was given by IADPO only. So we sincerely thank you for your efforts as far as epidermolysis bullosa is concerned. So now
It's my humble pleasure.
Professor Sunil Dogra from PGIMER Chandigarh. So it is a center of excellence as far as rare diseases are concerned. So he will talk about generalized pustular psoriasis, a rare disease, current gaps and challenges from the perspectives of patients, and what are the various role of patient groups in this disease as far as advocacy of this pustular psoriasis is concerned. Over to you, Dr. Sunil. He was our editor of Indian Dermatology online journal. Of course, it's a print journal also now. So I request Dr. Sunil Dogra to take over.
Thank you, Dr. Ramesh Bhatt, for your kind words. And thanks, Dr. Ratna Devi and the Ksham Health and Education Foundation for this opportunity to be with all of you today evening. I'll be speaking on generalized pustular psoriasis as a rare disease, a brief overview about its clinical presentation, what are the challenges in diagnosis, very briefly over the landscape of treatment, impact of GPP on patients' life, and how patients can contribute for the betterment of their groups and the treatment. So GPP, just to give you a background, was first diagnosed more than 100 years ago by Leopold von Jumbusch. He was an Austrian-German dermatologist. The disease is typically characterized by extensive erythema, edema, studded with superficial sterile pustules, which may coalesce together. And unlike psoriasis, this condition is also associated with systemic symptoms like fever, leukocytosis, arthralgia, and various other systemic organ involvement. The acute flares during the course of the disease can at times be life-threatening, and GPP is one subtype recognized of pustular psoriasis. There are few more subtypes like palmoplantar pustulosis or acrodermatitis continua of Halipo, where there is long-term morbidity, but they are not life-threatening, unlike GPP. So it is known to occur in all ages, though the peak age of onset is in 4th to 5th decade. It has slight female predominance. There are no specific treatment guidelines for GPP as of now, and the treatment policy is driven by experience from plaque-type psoriasis. About the prevalence, it is indeed very rare disease, but there are no specific figures available in the world literature because there is difference in the definition of disease in various studies, and the study design had been variable. There are few prevalence studies which are available from various parts of the world. In a study from Japan, the prevalence was 7.46 per million population, quite high in Korea as compared to Japan, 122, and about 180 patient per million population from Italy. So the estimates of prevalence varies because of variable definition of the disease, and disease as such is rare, so there are no large studies which can be done in this condition. So very recently, there was a consensus definition about the disease as proposed by European Rare and Severe Expert Network. They defined GPP as a condition having primary sterile macroscopically visible pustules on non-acral areas, that means not confined to the hands and feet. And then there are subtypes with or without systemic inflammation, with or without preceding psoriasis, and patient may have relapsing disease or persistent disease. So this is the working classification which is proposed very recently, and this can be used in most of the studies henceforth. Other subtypes are palmoplantar and acrodermatitis continua of Halipo. The pathogenesis of GPP is not very clear. Most of the time it is idiopathic, often flared by pregnancy, infections, hypocalcemias, sometimes drugs, and there is a loss of functional mutation in IL-36, which is identified in 23 to over 37% of the cases, and this mutation was first identified in year 2011. The most of the flares are reported after withdrawal of corticosteroids. So this is the strongest triggering factor for acute flares in GPP. So the pathogenesis is very complex. Ultimately, the inflammatory cytokine leads to chemotaxis of neutrophils in the epidermis, which manifest as pustules clinically with surrounding erythema. So these patients can develop pustular psoriasis de novo, or there can be a history of psoriasis vulgaris in the past in these patients. And the acute flare has a very serious illness-like presentation. It could be mimicking like sepsis. Patient can have high-grade fever. In the early phase, there is chills, then followed by fever, feeling of unwellness, arthralgia, followed by extensive rash all over the body, which is studded with pustules. And these are small 1 to 3 millimeter pustule, which can coalesce at places to form lakes of the pus. So this is a typical dynamic of clinical presentation of GPP. So based on the clinical presentation, GPP can be broadly classified into 3 phases: pre-pustular, flare, and chronic phase. So pre-pustular is patient who have past history of psoriasis vulgaris, and this can vary for 6 to 12 years before first episode of GPP. And the commonest trigger for GPP is corticosteroid withdrawal or treatment with high dose systemic corticosteroids. Then the flare is defined as when the body is involved by pustule covering more than 30% body surface area. About 60% of the patients may have just one flare in a year, whereas about 40% patient can have multiple flares. And then disease can enter into chronic stage where there can be localized areas of pustules, plaques, or both pustules and plaques, and patient can again enter into acute flare stage. So there can be flare and then chronic period. So this can recur again and again over a period of time. Like psoriasis, GPP is also associated with various other comorbidities like cardiovascular diseases, thyroid dysfunction, joint involvement, hyperlipidemias. And during the acute flares, there can be systemic involvement in the form of fever, metabolic complication, cardiovascular involvement. Then there can be kidney involvement, lungs involvement, pericardial effusion. And the onset of GPP during pregnancy can lead to placental insufficiency, miscarriage, and sometimes even stillbirth. The mortality during acute flares is reported up to 10%, whereas the older studies, they have reported mortalities up to 32%, particularly during the acute flares of the disease. Then about the quality of life in patients with GPP, it has been studied that their quality of life is lower than plaque and gutted psoriasis and is comparable to palmoplantar and psoriatic arthritis. That means they have disabling disease over prolonged period of time. GPP also have a adverse impact on their daily life activities, and most of the time they feel that they are undertreated for their disease severity, and approximately in a study only 1/3 felt that they were adequately treated for their disease severity by their physicians. Then about the humanistic burden of GPP, the hospitalization are relatively common during the flares, and the quality of life is severely impaired during the acute flares of GPP. And patients can have 1 to multiple flares over a period of time. And the persistence of lesions, the recurrence of flares despite treatment is an unmet medical need for these patients. Regarding admission in a study, it was found that after 2011, there were about 250 to 300 inpatient admissions each year in Germany because of GPP. GPP have a significant impact on quality of life, which has been studied by various metrics, and not only during the acute flares, but also in the chronic phase of the disease. However, the impact of GPP on the caregivers has not been studied in detail as of now. GPP also have significant impact on economic burden for the patient and their families because of hospitalization which they have to undergo during acute flares. And this hospitalization can vary from 10 to 14 days. Even during the chronic phase, they have to visit hospitals for their localized plaques or pustules and the treatment of other comorbidities associated with GPP. And they may be taking various topical and systemic therapies for treatment of their existing skin lesions or for the prevention of the flares in these patients. Something about the treatment, there is no standard treatment for GPP. The treatment guidelines is followed from plaque type of psoriasis. The extent and the type of therapy depend upon the severity of disease and associated risk factors in a given patient. The treatment goals usually are rapid onset of action, disease clearance, prevention of flares. And in this, the fast-acting drugs are generally preferred because most of the complications are known to occur during the acute stage. In Japan, there are few biologics which are already recommended for the treatment of GPP. However, there are no standard recommended guidelines in America and Europe. Mostly in our setting in India, we use conventional systemic therapy in GPP like acitretin, methotrexate, cyclosporine. Biologics are very difficult to afford for most of our patients in India. These are the conventional biologics which have been tried: anti-TNFs, anti-IL-17, anti-IL-23, and the newer in pipelines are anti-IL-1 and anti-IL-36. And recently, a phase 2 study of tocilizumab was published in NEJM, and the future for GPP treatment looks promising because of these specific anti-IL-36 targeted drugs. So apart from treatment, as Dr. Ritu and Paul also mentioned, there is a great scope for patient support organizations for the better treatment and access to treatment. And these patient support groups need to have better information, resources for the education about their disease, where they can contact for their disease management. We also need to provide some access to these costly medications to patients, and then they can have connect with other patients who are suffering from GPP in a given community or the given country. And similar to patients, even clinicians and researchers, they also need to have networking to get more into knowledge and disease information. There should be some research opportunities for the clinicians as well. And such kind of meetings or research day organizations can help even clinicians and researchers to do more in such rare disease areas. So thank you very much. Thank you for this opportunity.
Yeah. So Dr. Sunil, for your talk about generalized pustular psoriasis and the various insights related to that. So we will have a brief question and answer session. So I will first ask with Dr. Madhulika, is there an effort being made on the development of a national registry for patients with the rare diseases? Because you are in the technical committee, so whether there are any attempts being made, at least in centers of excellence or in other medical colleges?
Yeah. Dr. Ramesh, there is a registry which has been initiated by the Indian Council of Medical Research, and that is called a Registry for Rare and Other Genetic Disorders. And as of now, different groups have been included, and this is a hospital-based registry, as I was already talking about. And there are multiple institutions which are there. So the groups here are storage disorders, hematological disorders, which include thalassemia and hemoglobinopathies. Then there are neuromuscular disorders. There are primary immunodeficiency disorders and skeletal dysplasias. As of now, these are the groups which have been included in this registry. But this is just the phase 1, and in the later phases, it is likely that many more diseases will be included. In fact, the ICMR, the group which is involved in this, and the And the person who was coordinating has been telling that there are many requests to include something like genodermatosis, ophthalmological disorders, and so on and so forth. So maybe later on it can be done. And as of now, it is for these groups of disorders. And you must be knowing that there are many other independent registries also, which are there, and including funding through the ICMR, which includes a cystic fibrosis registry and some more. So as of now, this is existing, and I'm sure as time goes, more diseases will be included in the registry.
So you're muted, sir.
Okay. One more question for you is, because to understand the impact and epidemiological complexities of rare diseases, a bigger sample of persons suffering from these rare diseases is typically required, which we don't have. So they occur in a very small pool. So are there any approaches to address this problem? So is it possible to come out with guidelines with the limited number of patients as such?
So as I was referring to, the diseases which have been included by the ICMR are relatively common amongst the rare diseases. So if multiple institutions which are looking after these diseases, they pool up and have patients sort of collected in one group, so we will have significant number of patients. And as you are very rightly saying, for some of the, say, ultra rare disorders or the disorders which are actually coming into where we have only few patients. So I think in a country like ours, and being in a tertiary care center, we do see rarest of the rare disorders. So I think if we pool all over the country, and as you are saying that multiple institutions which include government and private, central, state government, so if we pool up and decide on that these are the disorders which we need to work on, we will have good number of patients. And this is extremely important primarily when we are talking of drug trials, because if somebody is planning a drug trial, they need to know the pool of patients which we have. So this can definitely be done. And like from your association, if you sort of start working on a registry for EB or maybe a combined registry or something like that. So I think people will contribute all over the country. I think that is definitely doable.
I think awareness among our doctors themselves.
Yes, I totally agree.
We initiated dermatological manifestation in COVID registry, and we haven't had any response in our website. American Academy of Dermatology or in other associations. Our response is probably lukewarm. That is the issue. So
that's right.
I will just
ask. We need to spread this information that how important registries are.
Yes,
I think it is extremely important.
I would like to ask Dr. Muralidhar, what efforts can be made to bridge the research gap in India for the rare dermatological conditions?
Thank you, Dr. Ramesh. I think the first thing has already been mentioned by Dr. Madhulika and yourself, in the sense that we need to have a registry. Now, to have a registry, you need to define what is it that you consider as a rare disease in dermatology. So we need to define that and then start a registry. Only then we will know what are the numbers we are dealing with. And when you have a registry, you'll have some idea on the need gaps. Once you have an idea about the need gaps, you'll know where the research has to be put in and what kind of funding or resources are required. And we need to see if this can be done at a single center or multiple centers. So it will depend a lot upon how we define and enroll which disease as rare, and how we maintain the registry and how diligent we are about it. And you're very right when you say that when you compared it to the attempt to make a COVID skin manifestations registry, if you have 60% of dermatologists saying skin manifestations don't occur in COVID, you won't get a registry. So the education of dermatologists also becomes very important in this, that we need to do this. So this meeting, I welcome all the more, because this should kick off a number of other ventures so that we ultimately have good research going on to identify diseases which impact the socioeconomic situation of the country And that is going to make a difference, because the final question the Ministry of Health is going to ask you that what is the cost benefit ratio of my funding research or drugs? That's the final common question. That's the denominator.
Yes, thank you, Murali. So now I will ask a question to Mr. Paul. How can patient advocates be empowered in order to make their voice heard at policy level? And also, what are the techniques should be employed to what can we do as a support group to influence policymakers on dermatological conditions?
Yeah, I think it's very important that we should always be present when those opportunities comes. It's for us before, it's really rare for psoriasis to be put on the agenda. But one of the strategies that we did is that whatever health events or talks that the DOH is doing, we make sure that we are always there. And whenever questions, wherever the Q&A comes, then we always take the opportunity to speak so that we can put our agenda on the table and that they could also listen to the challenges that we are having. And with those opportunities, eventually our organization became known to them already. And with the global resolution for psoriasis, it also helped us really to bring our agenda into the table. And I think for the rare disease, I think last year there's a resolution for the UN for persons living with rare diseases as well. I think it would also be a big bargaining chip that we can use to further the advocacy work for rare diseases. Thanks.
Yeah, thank you, Paul. Dear Ratna Devi, can you add on to this? How we can go ahead in India in relation to this?
Thank you for that question, sir. We have already initiated a lot of new patient groups, and our most recent experience was in stroke. And since stroke is very common, it wasn't very difficult to find people who either were at risk to stroke or were survivors of stroke. However, when we tried to do a similar patient group for something like, say, diabetes, retinitis due to diabetes, or something like atopic dermatitis, it was far more difficult. And I think a lot depends on how closely we can work with professional organizations. So for stroke, we work with the Indian Stroke Alliance and Association. And because it is a professional association, they were very supportive and we were able to find patients to create a patient group. If we can do something similar for dermatology and work with yourselves and your professional association, it won't be very difficult to start a patient group.
Yeah, thank you, Dr. Ratna. So final question to Dr. Sunil. Regarding, you talked about generalized pustular psoriasis. Of course, it is many a times it is a life-threatening condition. So what are the measures that we can adopt to raise public awareness and understanding about this disease?
Okay, so I think first is about awareness among dermatologists themselves, because diagnosis of GPP, there are no well-defined diagnostic criteria proposed as of now. So perhaps the exact figure is not coming out from our studies. That is one. And second, in various forums where we give, like we have a discussion on psoriasis, we should give due importance to GPP as well, because this is often not discussed, whether it's a World Psoriasis Day being organized by IADVL or it is any of the CMEs. So that is one part to raise awareness among dermatologists. And for the patients, I think on, say, World Psoriasis Day, we can have a dedicated leaflets or some amount of educational material on GPP, that this is another variant of psoriasis which is less recognized. And at times, patient may not be aware that this is a subtype of psoriasis for which they need to see a dermatologist. Many times these patients go to physicians and other specialists, and they may not be knowing what exactly and where they have to go.
So just to add to that, we are creating animated videos for patient education on atopic dermatitis. This is very simple layperson language on what is atopic dermatitis, how to manage it, and what to do when you have flares, especially for the severe form. And we are translating this into various languages because it is not just for India, so it will go global. We are translating it to many languages. Perhaps for psoriasis and for GPP, etc., we can do something similar if we have the resources for it.
Right, that will be a good suggestion, yes.
In fact, Ratna, we have lots of videos related to dermatological conditions. In fact, when I was the president, we had what is called as a Skin Safar Rath, where we went 12,000 kilometers all over India with a vehicle, and there was a screen, and we were focusing on of course, rare diseases, conditions like leprosy, vitiligo, psoriasis, fungal infections, steroid misuse. So all these conditions. So we can probably coordinate to have more patient information videos and other materials so that we can disseminate the knowledge about the various diseases. And also, you see, once we mention about skin diseases, always there is a myths and facts. So that we will have to highlight to our public. So with this, I thank Dr. Ratna on behalf of our panelists, and I hand over it to you.
May I make a small
Thank you,
point,
sir.
Dr. Ramesh?
Yeah. Yes, Murli.
No, regarding this videos, Dr. Ratna, I am part of the International Psoriasis Council. You just go to ipc.org. We don't have to reinvent the wheel. There are plenty of videos available. We have made those videos specifically for psoriasis patients.
Thank you, sir. I will have a look at that. Yeah, I will have a look at that. So thank you everyone for staying with us for the past 2 hours and for giving your valuable insights. So this was indeed a very good beginning, I would say, to be able to start something in dermatology. I know that India is so big, yet we do not have dermatological patients' voice being represented at a level that it should be. So I believe that this is a very good beginning, and that we have miles to go before we can achieve our purpose of starting this meeting today. My special thanks to Dr. Bhatt for chairing this meeting and for carrying it so well and for bringing in all the perspectives of all the speakers. Thank you, Dr. Madhulika Kabra. You are always an inspiration, and it is a pleasure always to have you on our panel. Special thanks to Dr. Swasti Charan for bringing in the government's perspective and giving us hope that the government is very much with us and will be able to work with them to see how we can include dermatological rare conditions into the national policy for rare diseases. Thank you to all our experts, Dr. Rajgopal and Paul. Special thanks to you. Special thanks to Ritu. Special thanks to Dr. Dogra for giving us insights into how PGIMR is working as a center of excellence. I hope to connect with you to learn more on what is happening in rare conditions. And as always, all these discussions, give me so much of insight, and I always end up believing that I have much more to learn than I know, and there is no end to the amount of knowledge that you can imbibe. So thank you all once again, and wish you all a very pleasant weekend. Thank you very much.
Thank you very much.
Thank you.
Thank you.
Thank you so much.